Welcome to the Global Robotic-Assisted Surgery Podcast, or GRASP for short. We release weekly podcasts featuring insights from leading surgeons and other surgical professionals. Our host for today is Mr. Nathan Nagel. He is a successful serial medical entrepreneur with 25 years of experience in medical, surgical, medtech and biotech businesses. We hope you enjoy the GRASP podcast.
Hello, my name is Nathan Nagel, and this is the Global Robotic-Assisted Surgery Podcast. Today I have Dr. Brian Cohen with me, and it's a pleasure and honor to introduce Dr. Cohen. So, Dr. Cohen, there's loads on the internet all about you, but in your own words, can you tell our audience about you, please?
It's interesting. I was not really involved in social media until a couple of years ago. Whatever's on there is probably, hopefully stuff that I've had influence on. But in a nutshell, I'm an orthopedic surgeon that grew up in New York, and I now practice in Ohio. I was fellowship trained in sports medicine, but have a wide array of different areas in orthopedics that I cover. I operate in the hip, the knee, and the shoulder, which is a little bit unusual. But where I started my practice in Central Ohio, I really had to be everything for everyone, as opposed to just an individual specialized. I enjoy health and wellness. I have two young girls that occupy a lot of my time. So very much, family is very important, friends, and obviously a successful outcome for my patients is utmost important.
And there's millions of orthopedic surgeons, but you've particularly succeeded. So what I'm interested to know is why. So what I found from speaking to people over the many years is there's different ways of living and there's different ways of approaching things. Because then of all the people, why do some people get to the top and some people struggle? Now, you did mention earlier about family, friends, and social life, which is incredibly important for sustained success. But how come you've reached the top of your game? How would you describe the way that you live and the way that you approach everything? Over to you.
I think it comes down to having focus, having a vision, wanting to, really be the best that I can be. I learned very early on in my education that I was not somebody that could, not succeed without putting in the work. So it's very much being dedicated to, what I'm trying to accomplish. I think success, is different for everybody. My goal has always been to, be a choice that people seek in terms of orthopedic care. I think it's important that when people come to see me, that they feel like they're being treated like a member of my family, getting attention, getting access. If it's something that I can't do, I'll let them know. If it's something that I feel very comfortable doing, I'll let them know that as well. And at the end of the day, I think it's just, you have to be confident in what you're doing and just be honest with yourself when you're making these decisions. So I think, like I said, success is defined differently by everybody, but I feel very comfortable in where I am in my career and very happy with the road I've traveled.
I think the key words that I brought out from there were that how you view patients, right? Because then if you're operating on kind of someone that you family, someone that you care, there's the passion and not just the intellect in goes in there. And then I'm bringing out that it's kind of like the value set that you bring to the game. And then, which is probably where you grew up as well, because then most of our values are instilled in us that from our family and where we grew up and cultural wise. And that often dictates, because I'm super interested in the personality types and value sets and how surgeons think, because then it does matter, because it does affect outcomes. So could you just give us, without too personal, your childhood, your bringing up and things like that? How did you learn this very family orientation?
Yeah, I mean, obviously, I think it goes back to my parents. thankfully they're both still alive. And, I have two brothers. So, 3 boys. I'm sure it was hectic for my parents, but it was nice to be in the middle. I got to be a younger brother and an older brother. But I like I said, I think it's just, my dad, just watching him do what he did and work hard as a pharmacist, probably not as rewarding as a career as he would have wanted, but knowing that this is what he had to do to support his family. So seeing him get up early and come home late and drive hours commuting into the city, I think that kind of gave me the foundation. But like I said, when I'm talking to patients, my parents are in their 80s. So if I have an elderly patient that's asking about an operation, I kind of related to, and I've said this before, I said, my mom's 80. I would not recommend this operation. I just had a patient the other day with a shoulder issue that I said, look, let's try everything but surgery, because they said, what would you do if I was your mother? And that's what I said. I said, I would tell my mom not to have surgery. I would say, let's exhaust all these non-surgical options. And if we can get you to the point where you're comfortable, then that's great. And there are issues that I dealt with personally in my shoulders that I'll say to a patient, if it doesn't affect your sleep and it doesn't affect your job, don't do the operation, live your life. I have shoulder issues. It doesn't affect my sleep. It doesn't affect my job. So I live with it, so I think it's just, really just trying to bring it back to how would I treat myself or a member of my family, and then kind of using that with, everything that I've learned over the 23 plus years that I've been in practice.
Does make sense. So when advising kind of younger surgeons, and then do you say that kind of like to do connect and to do empathize and to do have that kind of integral approach, which all sounds obvious, but I've met a lot of people who say disconnect because then you're less nervous and you don't feel the pressure less. When you do connect with people, do you feel more pressure because then it's valued, or how does it affect your pressure and stress around the anxiety?
Yeah, I mean, like they say in sports, you remember your losses more than your wins. So, everybody has complications, and anybody who says they don't have complications is probably not being truthful. So, I remember people from years ago that I've, struggled with medically. And so, I don't think that would change, based on how I treat people. I think it's important, and this goes just beyond your patients. This goes with how you treat, the people that you work with, whether it's in your office or in the operating room. Nobody comes to work to not do a good job. No surgeon, indicates an operation that they don't want to be successful in. So I think it's just, being calm, being confident, and keeping everybody in the room on the same page. And if you treat people well, you can get through anything. And I think it's important that not only do you carry that with your patients, but you also carry that with your staff and the people that you come in contact with.
It does make sense. Looking at that kind of competence and coolness and calmness, now I've read, but you're the expert, so you tell me that some of the downsides with a robotic-assisted TKA and THA can be that it can be slightly longer operative time. However, with experience, that comes back down to kind of comparative. So how do people get to that kind of like competence level, and how much does the augmented reality and virtual reality and the new different training come into this, or is it really down to just logging hours in the OR?
I definitely think experience matters. We definitely early on, we looked at our initial 50 cases done robotically, and then follow that up with the next 50. And the time has really come from, being more initially, and now, equal or less than when we did it manually. But I think that, like you said, it comes with experience and understanding, what are we trying to accomplish, and where does the technology, support and enhance what you're doing versus hinder or become kind of a gridlock, So really, I think over the years, and I've been doing robotics, now for about 6 years consistently. It's been, a blessing for me, and I think a blessing for my patients, and I think it just comes from that experience.
Now, on the train of personalization and connecting, I've read that some of the different robots now, such as the one that you on your site are an expert in, have more of like a personalized surgery approach because of like utilization of the CT scan, and then it's really down to their contours and their anatomy. So is personalized surgery the way forward that you think, and what do you see as the next step in personalized surgery?
Yeah, so with the MAKO, which is what we utilize, and it's very similar with a lot of the systems, but MAKO is based off a CAT scan, and it's very, like you said, it's very particular to the patient. And if you're doing bilateral knee replacements in a patient, it could be different operations in terms of how you're correcting the anatomy and even the size based off the patient's bony anatomy, from one knee to the next. So although the implants aren't personalized like some of these systems out there that create the implant off of an MRI, you do really match it to what the CAT scan is and what the bony structure is, both with the size of the implant you'll be using based off the bony structure, and also the anatomy and the alignment you're trying to correct. What the future looks like, definitely augmented reality is on the upswing, and I've been involved in some of those initial visuals. Initially, it was more just the surgical plan is now in your field of view while you're doing it, which can be distracting if it's not really aiding the surgery. Newer things that are coming out are actually being able to register the bony anatomy, whether it's in the shoulder or the knee or the hip, virtually, and then being able to identify landmarks based off of that registration. So I think the evolution is going to be where we do a lot of our surgical planning and identification of landmarks augmented. But there is something to be said of having, specifically in the knee when you're doing angular cuts, to have controlled cuts, and also the safety factor of the device not to go past the bony landmarks, and then get into, areas of concern, like in the back of the knee, going too far when you're cutting the tibia and getting involved in the neurovascular structure. So there is a safety benefit to having that controlled by, we'll call it robotics, but, based off of a CAT scan and mapping the bony anatomy accurately.
And then intraoperatively, I mean, there's well reported the benefits, but what about postoperatively? Looking at THA and then dislocations and things like that. You've been doing this for 6 years now. How have you found that the outcomes post-wise?
Yeah, so one of the things that I've personally noticed is that recently we switched to almost exclusively in the knee the ingrowth implants, so the cementless implants. And what I've seen is our revision rate in the first 2 years is basically zero.
Wow.
Which is really different than when we're using cemented. There was always those outliers that the cement fixation would not hold or whatever the reasons were. And I found that we were doing revisions within the 2 years on our cemented, but we haven't seen that with the cementless. I'm not saying that cementless is an end all be all, but in what we're experiencing, or I'm experiencing, it has been very successful. And then as far as dislocation, I'm a traditional posterior approach, surgeon. It's how I was trained, how probably most of the people in my age group were trained. Anterior has its place. But, like I tell patients, I had a patient yesterday talk to me about hip arthroscopy. I've done one hip arthroscopy 20 years ago. And I told him, I said, I don't think you want me to be my second patient who had a hip arthroscopy. So I tell patients, I'm comfortable with posterior approach. This is where I've seen my success. I have patients who I would say do as well as an anterior approach, if you compare them side by side. So in my hands, posterior approach is what's best. Robotically, what we've seen is, any risk of dislocation has really gone down. It's one out of, every 100. It's a very rare occurrence that we see this.
Okay.
And I think it's because, now going back to the bony anatomy off the CAT scan, we're using the right size implants, and intraoperatively, we're getting a better sense of anatomic positioning, based off the bony anatomy. And then also what I'm seeing less of is, complaints of leg length discrepancy. So, we're really understanding where the leg length is pre-op and where we finish post-op, and having those conversations with the patients. So I think that there's a value to objective data, and having conversations with patients around what we're doing intraoperative.
Makes sense. Now, you mentioned preoperatively. Now, I've read, you tell me how much true it is part of your success is not just what you do in the OR, it's actually all the stuff beforehand, meaning that you spend a lot of time educating the different referring physicians and working with people to make sure that you get to the right candidates. So therefore, you're not going, no, not you, no, not you, no, not you. How much of an ecosystem do you think of as a value for the surgeon?
One of the things that we created years ago was a kind of an internal referral system. So, the surgeon is kind of the end of the pathway for patients. So what we've done is I've surrounded myself with non-operative orthopedic or sports medicine doctors that really can understand, the patients that they can treat successfully without being referred to me, whether it's injections or biologics or, or physical therapy, whatever, they feel they have in their tool bag to treat these problems. But also recognizing those patients that, need to be referred on to surgery, having failed their non-operative approach, or have come in with an acute injury that really requires surgery. So it's working with them closely. And then, once again, not every patient that gets referred to me is an operation, and we have conversations about, what they've done that has been successful and what they can do additionally that may not have been tried. So I think, what I tell patients is that you can't have a surgical complication if you don't have surgery. So let's figure out what we can do non-operatively to get you to where you want to be. And if we can't do that successfully non-operatively, let's talk about the surgical options.
Makes sense. So do speak to people who say that, they're not logging the right hours with the right patients because they're not getting the right referrals. And it seems that your approach to getting that ecosystem right has been part of the success, because if you're managing to get the right patients, you log in the hours, you're getting the right cases, your exponential count goes off. It's trying to just bring it out for the residents to say it's not just in the moment, but your thought approach seems to be that it's the whole bigger picture of the surgeon within the ecosystem rather than just the surgeon at the table.
Yeah, I mean, we don't do this alone. This is not, orthopedics, as I've said before, and even on social media, it's a team sport. And it's not just a team sport in the operating room, which is obviously the hyper-focused portion of what we're doing. It's a team sport in how the patients, come to you, and how you treat them, and what, nobody wants to see a surgeon that the only thing that comes out of their mouth is that, you need an operation. I tell patients all the time, we don't treat x-rays, we treat people. You may have an x-ray that looks like your knee says you need a knee replacement, but clinically you may not have those issues, and you may, be dealing with something else that may be unrelated to your knee, but the x-ray was done for whatever reason. So, like I said, we don't treat people, we don't treat x-rays or MRIs, we treat people. And the goal is to, avoid surgery unless it's necessary.
And looking at the scans is I'm making an assumption here, but the quality of the interpretation of the scans and the people doing the CT scans also make an impact on the personalization of the operation for you as well.
Correct. And the scans for, the CT scans were not a traditional knee scan. If we're doing a total knee, or traditional hip scan, if we're doing a total hip, it really incorporates the entire lower limb to get the alignment and stuff. So there is definitely quality control that goes into it. And so unfortunately, it's one of those situations where if you don't have what you need, sometimes you have to repeat these scans, which is obviously something we try to avoid and try to educate the techs that are doing these scans that, this is what we need. So it's a one-off when we have that situation, but we're not going to do something with inappropriate data. The plan is based off of the scan. If the scan's not right, then the plan's wrong.
Makes sense. So just now let's start to go into looking at the teaching of the residents. So let's say someone's, excuse me, a very proficient lap surgeon, and they want to start on their journey to become a RAS surgeon. What would you advise someone next in terms of like next 10, next 5 steps or something like that to moving into a new realm?
Yeah, I think whenever you're going to take on new technology, I think it's important to, do your research. Before I started with the MAKO, I did visit, a surgeon who had been doing many of these. We spent the day with him and watched his process. And then also, I've seen a lot of technology that I just didn't feel was right for me. I'm not saying that the technology is not right for somebody else, but it wasn't right for me, whether it was the CT guy, the mapping that we used to do with the different technologies that were out there. But I think it's important to, do the research, spend time with somebody who does these procedures and understand where they see the advantages. And then obviously, there are labs that you can do through these different companies to get an understanding of how the process works. And then you just got to figure out, is this something that you feel that you can incorporate into your kind of continuum of how you do your operation? And is it a disruptive, or is it kind of an additive? One of the things, with these robotic technologies is that there's a line of sight that needs to be unblocked so that the computer can see where the patient's leg or hip is in space. And there's definitely a nuance to how do you, we call it MAKO limbo. How do you position yourself so that you can be an assistant or do what you want to do surgically and not get in the way of the arrays that need to be seen to accomplish the goals.
That makes sense. And from a lot of people that we've spoke to, and over the many years of working with surgeons, there tends to be a lot of travel involved in this learning. So if you want to learn from someone, you've got to, sometimes people just generally do have to travel to be with their proctors or to be with the people that want to learn from, because yes, there's a tremendous amount that can be done online, but it's not as good as seeing someone, being next to someone.
Yeah, I think it's very important to be, especially in the operating room, to be in. Over the years, we've trained, over 100 surgeons from different parts of the United States and even parts of the world. We've had surgeons from New Zealand in town. We've had surgeons from Germany over the years. And what we were able to do is we were able to let them actually scrub into the operation, obviously, so that they could see specifically more in the shoulder, where the glenoid exposure is really something that you need to be looking in, as opposed to, you can't see it from, behind the surgeon's shoulder. So you have to be right in there. So how do you get exposure and stuff like that? So I think it's important not only to be there or be present, but also if you have those opportunities where you can actually scrub in, you talked about residents and their future plans. A lot of them have elective time that they can go spend time with other surgeons. When I was a resident, I spent time in Sydney, Australia, with Professor Sonneban, who's a world-renowned shoulder surgeon in Sydney. And that was a great experience to be, hands-on in there, seeing how he does things and how he gets his exposure. So I think there's a lot to say, or the value of seeing things from a different perspective.
So really, it's if they want to succeed, they must be willing to travel.
Well, yeah, Sydney is a little bit, that's travel.
Yeah, definitely. And then in addition to learning from other people, because then how else does someone in terms of like, because it is a different thought process and it is a different haptic process as well of going from lap to RAS. How can they train themselves in terms of a whole different neuroplasticity of training the hand-eye coordination of it all? What else can they do?
I don't think it's something that you can, like if you're an athlete, go in the gym and, work on your running and stuff like that. I think in these situations, because, when I trained, obviously robotics was, not, I would say it probably wasn't even existed, 25 years ago. I was able to accomplish, what I needed to. So I think it's really just, like I said, it's spending time with the people who do it. So understanding why and how it works. And then also, when you can, getting in a lab and doing the cadaver work, because that although not as realistic as surgery, is as close as we have. I don't think augmented reality for training in this situation is going to be as helpful. I think it's more of a hands-on with a cadaver. And then spending time, if you have that time to work actually and scrub in and learn a little bit more.
So really, there just is no real proper substitute for just doing it.
In this situation, I just don't think it exists.
That makes sense. What other kind of misconceptions do people have? What kind of common questions from patients that you hear all the time?
Yeah, so I think that like I said, first of all, the biggest one is like, what's the robot doing? Are you going to be in the room with it? So it's really educating them on, this is obviously an extension of me, as opposed to sitting in the corner and playing a video game while it's working on you. I think that patients, they're concerned, is there a higher cost? And right now, the only additional cost besides whatever's open to do the procedure, so the soft goods, is really the CAT scan. Beyond that, there's not a higher charge for the procedure, whether it's done manually or robotically. It's the same charge. And I tell people, it's very similar to manual in terms of from the outside, it's going to look the same. But based on what we do intraoperative, specifically in the knee, we're not doing intramedullary alignment guides. So you're not necessarily violating the canal as much as you would for a traditional or a manual surgery. So the potential there for less bleeding, less pain is there. I haven't dug down deep to say that that's, been a benefit to my patients or not. I don't feel like I'm getting calls for pain medication like I used to, but I can't say that that's a true statement in and of itself. Things have changed as far as pain medication across the board. We're using a lot more additional types of medications to control pain and not just narcotics. And that's been very important for our success.
That makes sense. I mean, the papers have got excellent results on the post-operative care around it all. And then more than just complications, we've started to touch on the subject with other people around prehabilitation of, and it's not massively discussed in surgery, but do you have any kind of prehab program in terms of diet, nutrition, and exercise and lifestyle before they come in to see you? And have you found that that's any difference?
So, I definitely think that the best you can be going in, whether it's, health wise or, weight wise and stuff like that, is gives you the best chance to coming out better after surgery. So, we do try to incorporate those things that, we know work, keeping their A1C below 6, keeping their BMI below 40, having them not smoke for 2 weeks before surgery. We try to enforce these things. Unfortunately, there are patients out there that, they are their BMI is way above 40, but they're debilitated. And, new literature coming out says that, they deserve treatment as well. Obviously, I had a patient come in yesterday. Her hip it's gone. I mean, it is just, she had a fall 4 months ago, probably had a femoral head fracture that she never got treated. And now, the ball is half its size that it should be, and it's rubbing bone, and she's miserable, but her BMI is, over 45. But we had the discussion that, look, your surgery is going to be more challenging technically. The risk for you are going to be higher. She has talked about, potentially some type of bariatric type surgery, but that requires a long runway. So we had a very personal conversation with her and her husband about, what does it look like if we do surgery? What are we faced with in terms of, the goal is not to make you worse than you are, but, the risks are that, if you have an infection or if implants are put in not the anatomic position because of your size, you run the risk of dislocator, and those can make you worse than you are right now, even though you feel like this is the worst. So we had the conversation. We'll have another conversation. It's not, we just don't meet and go right to the operating room. We have to work these things out and make sure that everybody's on the same page. But ideally, we would love everybody to be, BMI of 35, non-smoker, active aerobically, walker, runner, biker, something that gives us the best chance for them to have the best outcome. Unfortunately, that's not everybody that walks in the door.
I understand. And then for patients with a larger BMI, is there any advantages to using the robot over manual in terms of reach and ability? Because there still is a physical space to maneuver around.
Yeah, initially I was concerned that it would be harder to get the robotic arm into position. On those patients that we have operated on that have a larger BMI, we haven't seen that. So I've been actually very happy with where the robot comes into play. And I feel like it gives me a better visualization, because visually I can't see everything I need to see because of the depth of the acetabulum specifically, with regards to position and stuff. So I feel like it gives me more of a comfort knowing that, we're getting into what anatomically we want to do. So I've been happy with the robotic arm in these larger patients. In the knee, it's a little bit less concerning because, the knee is a lot easier to expose. It's not as deep, I should say.
I was thinking more of hip and then positioning and then the team around the person and then the physical reach, and then because then you can't adjust your arm length. So
yeah. Orthopedics is definitely an active surgery. It's at times you end the day and you're just physically and mentally exhausted. I had a post recently about our Monday and Tuesday of this week. We did 6 revisions, and it was physically and mentally exhausting and challenging, and just trying to maneuver around all these things that we're trying to overcome from previous surgeries.
Does make sense. So in terms of younger surgeons wanting to go into orthopedics, is part of the advice go to the gym first?
I think that it is important to be physically fit. Whatever your passion is in terms of exercise. I like to do some weight training in the morning, then I do aerobic exercise, for over an hour. So I think that has helped me be successful in terms of my ability to get through these long days. So I think there is a benefit to that. Also, if you're somebody that does like to exercise, and you try to do it before so that you're not trying to get there at the end of the day and shorten your day.
And one of the main areas that I hear about all the time is back issues with orthopedic surgeons. I'm making the assumption that your weight training in terms of strengthening your abs and your abductors and everything like that helps you to stabilize your back when, quite frankly, getting all different positions while operating.
Yeah, I think core is very important, just for living a more painless lifestyle. But definitely, like you said, some of these patients and what we're doing, we're definitely, and like I said, the MAKO limbo, we're contorting our bodies to get into a position, and that does put a lot of strain across your back. Fortunately, I when I do get back pain, it's something that I could work out in the gym. But I think it's important for core exercises to be successful long-term in surgery.
Because it is healthcare, self-care. Unless the surgeon is looked after, it's very difficult. It's like the lifeguard with a broken arm.
Yeah,
we've got to look after our lifeguards. You guys are, everyone. The females are all the lifeguards.
Yeah, no, I agree. I think it's important. Self-care is healthcare, so it's important to be, practice what you preach, I guess, would be the thing. So, fortunately, I don't have any major vices that I'm concerned with. I think my biggest problem is that I do have a little bit of OCD and do have to exercise in the morning, and I'll get up early to do that. And so I'm sure that impacts my, just it is what it is, and I'm good with it.
I have diagnosed OCD. I prep all my meals. I have my ice bath. I do my gym. My wife thinks that I'll get anxiety if I break my routine. She might be right.
Yeah, and I agree. I think I'm the same way.
But it helps I'm looking at long term, it's sustainability. It's not just academia or technical. It's kind of even business sat down all day is a physical sport.
Yeah.
Because there's so many people with unhealthy business is unhealthy.
Yes.
It's kind of like the extreme. We're sat down all day, and in orthopedic surgery, you're physically working all day. So it's both extreme ends. I suppose it would be the question for you is if you would ever need a joint operation, who would you choose?
I've needed a few operations in my day, knee scope, a triceps tear. I chose the surgeons that trained me, at my fellowship. I think it's important, to trust who you're going to, and those are the people that I trust. I think, patients need to do their research. I think talking to other patients that have had procedures by the surgeon you're going to is important. Give you an idea of who they are and their outcomes and stuff. So I think, and that was what it was for me. I went to somebody that trained me that I appreciated.
Your website is comprehensive, so I do like that about it. So it's because then people can, I would say most people look up their surgeon before deciding yes or no. So I think the clarity of a website with which can often seem trivial to most surgeons, but I think that it is important because they do want that to read things and do want that degree of confidence. And it's like that official review. And I noticed that you've also got patient reviews on there as well, with which people need. They do want to look people up, and I'm sure that there's lots of literature that the less anxious a patient goes in, the better outcomes there are afterwards.
For sure. Yeah. I think that access is important, whether it's access to information or access to, talking to me personally. I'm very happy to take a phone call or meet with a patient, let them kick the tires, so to speak, and see who I am and what I'm about. But yeah, I think it's important, the patient testimonials are great. It's great to have somebody that has had the experience that could say, yeah, I did this and this is what my outcome was, and I was very happy, and I felt like I was treated like a person as opposed to a number, and all those things are important.
It's really useful. Dr. Cohen, thank you ever so much for being very open and having a really insightful conversation. There'll be a lot of surgeons that's going to be, and non-surgeons that's going to be listening to this, that can take great insights, because then a lot of our audience want to learn how to be where you are. How does the person think? How do they act? How do they behave? What did they learn? What are their values? It's that whole teaching. And a lot of people, the main questions that we get when people email in to say, how do I become one of your guests? How do I do this? So thank you for really being open. Maybe I can just see that part of the future might be you as an avatar speaking different languages, teaching people, unless you speak 100 different languages, but maybe we can map you in an avatar and have you teaching in Chinese.
I enjoy communication, so I'm very interested in people who are interested in, the things that I'm interested in. So, anybody who's interested in orthopedics or medicine in general, I'd be very happy to give them, my approach, my opinion. As we know, there's different ways to skin the cat. So everybody, I'm not saying my way is the only way, but my way has been successful for me. And it may be successful for somebody else, and I'm more than happy to not only share time. We always welcome any interested visiting future doctors that want to spend time in the operating room with us and get a hands-on experience of what we're doing, to reach out, and we'd love to have them.
It's decades of experience and wisdom and knowledge in your head. One day, hopefully, we can get to the point of going, hey, we should download this person.
That'd be great.
Dr. Cohen, thank you ever so much for your time.
Thank you for listening to the Global Robotic Assisted Surgery Podcast, or GRASP for short. Please subscribe to be updated with all of our new podcasts coming out. If you would like to learn more about robotic assisted surgery, please go to www.roboticsurgerypodcast.com.